Hello, this is Jeanne Poole. I am the editor-in-chief of the Heart Rhythm O2 Journal, and this is the August 2025 podcast. I'd like to welcome you all to this really packed issue for this month. We start off with a very interesting and important paper titled Safety of a Pacemaker Mode Intended to Protect Patients by Dr. Robert Hauser and colleagues. As the readers and listeners know, pacemakers and implantable defibrillators have had a number of FDA recalls and advisories over the years. Usually these have minimal severe risk, with the percentage of potentially affected patients way less than 1%. I think we all can recall what happened with the St. Jude Reata lead. That had a unique risk of an insulation breach, sometimes demonstrating externalization of the inner coils. And while there were reports at that time of possible related deaths, the overall risk of electrical failure was actually quite low. Dr. Robert Hauser is often a clarion call to clinicians for us to thoroughly understand these advisories and recalls. In this study titled Safety of a Pacemaker Mode Intended to Protect Patients, Dr. Hauser discusses the alert, which is a rapid battery impedance rise in a subset of the Boston Scientific pacemakers. This event then can trigger something called safety mode. Safety mode is a hardware mode intended to protect patients from loss of patient capture in the setting of overwhelming EMI. Safety mode sets the pacemaker to BVI, or biventricular pacing, at 72.5 beats per minute. Unipolar configuration with a sensitivity of 0.25 millivolts. The problem is that this mode may place some patients at risk of harm from inhibition of ventricular pacing. In this paper, Dr. Hauser reports on adverse events identified in the MAUDE database that may have been related to the problem of safety mode trigger due to this abnormal rapid risk in battery impedance. We all know that the MAUDE database is certainly incomplete, but that is the database that we currently have to use to try to identify relationship or even causality when advisories or recalls exist. The key findings of this paper are that the safety mode in Boston Scientific pacemakers is intended to protect patients. However, its high unipolar sensitivity can cause pacing inhibition owing to oversensing of mild potentials and electrical noise. The authors found the safety mode resulted in major adverse clinical events in pacemaker-dependent patients, including death, asystole, and syncope with serious injuries. The authors also note that other manufacturers' backup or reset modes did not inhibit pacing, and finding that prophylactic replacement may be appropriate for vulnerable pacemaker-dependent patients. This paper is followed by a thoughtful editorial by Dr. Arshnil Kokar and colleagues. The next paper is titled First European Experience with a Leadless Atrial Pacemaker by Dr. Ilya von Felten and colleagues. The objective of this author's study is to evaluate the implantation, safety, and device performance characteristics of a first real-world European use of an active fixation atrial leadless pacemaker for either dual-chamber or single-chamber pacing. This is a prospective single-center, single-operator analysis, including consecutive patients undergoing implantation of an active fixation atrial leadless pacemaker, either as a standalone therapy or as part of a dual-chamber leadless pacing system. The authors included 45 patients, 22 of whom, or 48.9%, underwent a de novo dual-chamber, 9 patients who had an upgrade from ventricular single-chamber to dual-chamber, and 14 patients who had an atrial single-chamber leadless pacemaker implant. All implants were successful and did not require device repositioning. The median procedure time was 35 minutes. Complications occurred in 2 patients, or 4.4%, who developed pericardial effusions. Sensing, impedance, and stimulation thresholds of the atrial and ventricular devices remained stable or improved over a median follow-up of 21 days. The estimated median battery life of the atrial device was significantly higher in single-chamber versus dual-chamber settings, 11.9 years versus 5.8 years. The authors conclude that their first real-world European experience demonstrates that leadless atrial pacemaker implantation can be performed efficiently and safely with satisfactory device measurements during the early follow-up period. The title of the next paper is Prediction and Impact of High Burden of Ventricular Pacing in Patients with Pacemaker After TAVR. This is by Dr. Frederic Anselm and colleagues. As way of background, the authors note that a high burden of RV pacing increases the risk of heart failure hospitalization, but that data on predictive factors for developing a high burden of RV pacing in patients with permanent pacemaker implantation after TAVR are limited. The authors aimed to identify these predictors. The authors included consecutive patients who underwent permanent pacemaker implantation after TAVR between 2013 and 2023. Dual-chamber pacemakers were programmed to minimize ventricular pacing. A high burden of RVP was defined as a pacing percentage of greater than 20% at 3 to 12 months of follow-up. Amongst 193 patients included, 92, or 47.7%, had greater than 20% ventricular pacing at the 3 to 12-month follow-up period. The authors identify the following variables as predictive of high burden of ventricular pacing: male gender, permanent atrial fibrillation, or high-degree AV block as the indication for the permanent pacemaker implantation. The authors then derived a risk score for predicting greater than 20% V pacing. This was labeled the H2AS score. The authors assigned 2 points for high-degree AV block, 1 point for permanent AF, and 1 point for male sex. The authors then report that the H2AS score identified a 68% prevalence of greater than 20% V pacing. Also, over a median follow-up of 27.7 months, greater than 20% V pacing was associated with a higher risk of all-cause mortality or heart failure hospitalization. The authors conclude that a high risk burden of ventricular pacing of greater than 20% could be anticipated using a readily available pre-PPI risk assessment, and that the H2AS risk score may assist clinicians in determining the most appropriate ventricular pacing strategy for patients after TAVR with an indication for permanent pacemaker implantation. The next paper is titled National Tunisian Multicenter Prospective Study on Cardiac Implantable Electronic Devices, the Tunisian Nature CIED Study, 1-Year Complications and Predictive Factors by Dr. Sonia Shabrak and colleagues. This paper describes the prevalence of CIEDs in Tunisia, noting that it is rising because of increased life expectancy and broader indications. This has led to a higher incidence of complications related to vascular access, device pockets, leads, and patient characteristics. The objectives for these authors were to evaluate the prevalence, types, and predictors of complications occurring within the first year after CIED implantation and to profile the demographic and epidemiology characteristics of CIED recipients in Tunisia. The authors used the National Tunisian Multicenter Prospective Study on Cardiac Implantable Electronic Devices, which is a nationwide prospective study. Patients were consecutively enrolled between January of 2021 and February of 2022. These patients all underwent de novo implantation of pacers, ICDs, or CRT devices, as well as generator replacements and upgrade procedures. Patients all attended 4 follow-up visits over the first year. For this study, the authors enrolled 1,500 patients with a mean age of 70 years. Most, 86.5%, received conventional pacemakers. The overall complication rate was 8.6%, with 129 complications in 80 patients. No significant associations were found between age or gender and complication rates. However, overweight and obesity were independent predictors of overall complications. Procedures that were performed in private healthcare settings were associated with a 56.2% reduction in complication rates. Generator replacements were linked to a 64.2% decrease in complication rates. Conversely, urgent or out-of-hours procedures increased the risk of complications by 62.7%. And finally, procedures performed by non-electrophysiologist implanters were associated with an 89.5% increase in overall complication rates. The authors conclude that complications were more prevalent with cardiac resynchronization therapy devices, and finally, that identifying specific procedural predictors may pinpoint patients at higher risk, affecting personalized treatment and CIED implantation strategies. Up next is a paper titled Outcomes in Patients with Cardiac Amyloidosis Undergoing Catheter Ablation for Atrial Arrhythmias by Dr. Adrian Petzel and colleagues. The authors offer as background that cardiac amyloidosis is characterized by atrial myopathy, which predisposes patients to atrial fibrillation and other atrial arrhythmias. Although catheter ablation of atrial arrhythmias is effective in the general population, the authors posit that its efficacy and safety in patients with cardiac amyloidosis remains unclear. The study aimed to evaluate outcomes in patients with cardiac amyloidosis undergoing catheter ablation for typical atrial flutter and left atrial arrhythmias, and to assess the presence and influence of left atrial low voltage areas in these patients. The authors retrospectively analyzed patients with cardiac amyloid undergoing first-time ablation for typical atrial flutter or left atrial arrhythmias. For the latter group, left atrial electroanatomic mapping quantified left atrial low voltage areas for both burden and distribution. The primary outcome was arrhythmia recurrence at 1 year. Additionally, long-term outcomes over the maximum follow-up period were assessed and correlated with left atrial low voltage areas. The cohort included 36 patients, typical atrial flutter in 11, and other left atrial arrhythmias in 25, with a mean age of 75 years, 81% men, and 64% wild-type trans-trireten amyloidosis. Recurrence of atrial arrhythmias after 1 year occurred in 10 patients, or 40%, after left atrial arrhythmia ablation, and in 3 patients, 28%, after typical atrial flutter ablation. Left atrial low voltage areas were seen in 73% of the patients undergoing left atrial arrhythmia ablation, and it occupied 50.4% of the left atrial surface, most commonly the posterior wall, in 53%. However, its presence did not correlate with long-term arrhythmia-free survival. Procedure-related complications occurred in 16%, particularly heart failure decompensation. The authors offer as key findings that 1. In patients with cardiac amyloidosis, cardiac ablation of left atrial arrhythmias resulted in 60% arrhythmia-free survival at 1 year, but recurrence increased with longer follow-up, such that only 40% were arrhythmia-free at 4 years. 2. Left atrial low voltage area were highly prevalent, 73%, and extensive, with mean 50% of the left atrial surface, but did not predict arrhythmia recurrence following ablation. 3. Patients undergoing ablation for typical atrial flutter had favorable acute outcomes, 100% CTI block and no typical atrial flutter recurrence, but 55% developed new atrial fibrillation or atrial tachycardia during long-term follow-up, highlighting the underlying atrial disease. Next, procedure-related complications were notable and occurred in 24%, especially decompensated heart failure in patients with cardiac amyloidosis undergoing left atrial ablation, underscoring their clinical fragility. Finally, despite structural atrial remodeling, catheter ablation remains a viable rhythm control strategy in patients with cardiac amyloid with symptomatic atrial arrhythmias, though recurrence risk and complications warrant careful patient selection and follow-up. The title of the next paper is Granger Causality Connectivity Analysis of Persistent Atrial Fibrillation Dynamics Reveals Posterior Wall Mechanistic Insights by Joseph Barker and colleagues. As way of background, the authors note that adjunctive posterior wall isolation to pulmonary vein isolation has not demonstrated convincing benefit during atrial fibrillation ablation. To provide mechanistic insight for null PWI trials, the authors undertook Granger causality analysis of non-contact left atrial electroanatomic maps. The goal was to uncover patient-specific AF dynamics and describe a proof-of-concept approach to targeted PWI after PVI. A prospective cohort study was undertaken at the Royal Brompton Hospital in London, UK. Consecutive patients undergoing PVI with non-contact mapping using ACOMAP or Acutus Medical before and after PVI were included. In 21 patients, Causality Pairing Index, a GC measure of organization, was unchanged after PVI. Directional dispersion, quantifying conduction heterogeneity, was lower in the PW than the rest of the left atrium and increased after PVI, whereas there was no change in the rest of the left atrium. Posterior wall net outflow overall decreased after PVI, with a minority of patients exhibiting a net positive outflow from the posterior wall. The key findings are that 1. Granger causality analysis applied to non-contact atrial mapping reveals patient-specific AF propagation patterns and connectivity. 2. Following pulmonary vein isolation, the left atrial posterior wall typically becomes a net sink, suggesting it is less likely to act as an AF driver. and explaining the lack of positive trials in this space. Third, directional dispersion, a measure of conduction heterogeneity, increases in the posterior wall post-PVI, indicating altered fibrillatory dynamics. And finally, GC analysis may serve as a valuable clinical decision tool to identify patients most likely to benefit from adjunctive posterior wall isolation, potentially enabling personalized AF ablation strategies. The next paper's title is Active Esophageal Cooling Reduces Periesophageal and Vagal Nerve Injury in Radiofrequency Current Pulmonary Vein Isolation by Dr. Dirk Grosse-Menninghaus and colleagues. As a way of background, the author notes that damage to periesophageal tissue may occur following pulmonary vein isolation. Active esophageal cooling has been shown to reduce the incidence of mucosal esophageal injury, probably by dissipation of heat and inhibition of inflammation. Whether it also protects the periesophageal vagal nerve plexus and reduces gastric hypomotility and food retention is uncertain. The purpose of their study was to analyze and compare the incidence of esophageal and vagal nerve injury following radiofrequency current PVI with active esophageal cooling to that of luminal esophageal temperature monitoring. Using endoscopy and electrogastrography, esophageal and periesophageal injury were prospectively assessed following RF-PVI with active esophageal cooling and compared with RF-PVI with luminal esophageal temperature monitoring. A total of 64 patients, 58% of whom were men, undergoing RF-PVI for AF with esophageal cooling under deep conscious sedation were prospectively studied and compared to 52 patients who had luminal esophageal temperature monitoring. Following RF-PVI with active cooling, 4.7% had mucosal erythema, 15.6% had new onset food retention, and 14.1% had ablation-induced vagal nerve injury. In comparison, the luminal esophageal temperature monitored group showed 11.5% with mucosal esophageal lesions, 26.9% with new onset food retention, and 28.8% ablation-induced vagal nerve injury. The rate of any esophageal injury per patient was decreased by a factor of 0.51. The author's key findings are that active esophageal cooling in RF pulmonary vein ablation reduced the incidence of mucosal esophageal lesions, vagal nerve injury, and new onset food retention by about 50%. Similar to PVI without cooling, post-procedural vagal nerve injury incompletely overlapped with other manifestations of periesophageal injury. And finally, active esophageal cooling allowed shorter procedure times and was used successfully in patients undergoing PVI under sedation with unassisted respiration. The title of the next paper is Risk of Acute Pericarditis After Pulsed Field Ablation Pulmonary Vein Isolation by Dr. Juliana Perez Pizon and colleagues. As a way of background, the authors note that post-ablation pericarditis can occur after PVI using RF ablation. Post-field ablation, PAP, is anticipated to be lower based on its non-thermal nature in initial studies. The authors aim to evaluate the incidence of post-ablation pericarditis after PFA and compare this with rates of radiofrequency ablation-related post-ablation pericarditis. They prospectively identified cases of post-ablation pericarditis in 322 patients who underwent PFA/PVI ablation between April 2024 and December of 2024, and 1,750 patients who underwent RFA/PVI between January 2022 and December 2024. Logistic regression analysis was used to assess the factors associated with post-ablation pericarditis. Acute pericarditis occurred in 14 PFA patients and 60 RFA patients, which was 4.3% versus 3.4%, with a non-statistical difference. The median time to post-ablation pericarditis presentation was 4 days for PFA and 1 day for RFA, also non-significant. There was no significant difference in triage strategies or the need for a revisit owing to persistent symptoms between the energy types. For treatment of post-ablation pericarditis, colchicine alone was used more frequently, and after adjustment, female sex and obstructive sleep apnea were associated with an increased risk of post-ablation pericarditis, whereas having a previous ablation in older age decreased this risk. The author's key findings were that first, rates of post-ablation pericarditis after pulsed field ablation and radiofrequency ablation pulmonary vein isolation are similar. Second, risk factors for post-ablation pericarditis are similar between RFA and PFA and include sleep apnea and female sex. Third, having a previous ablation and older age are associated with a decreased risk of post-ablation pericarditis after PFA and RFA. Finally, post-ablation pericarditis with PFA follows a mild clinical course and responds well to standard treatment and carries a low risk of progression to pericardial effusion and tamponade. The next paper is titled Differences Between Two Cryo-Balloon Systems in Achieving Successful PVI in Patients with Challenging Anatomies by Dr. Yamashita and colleagues. A new technology, the Poole cryoballoon system, was designed to enhance maneuvering and stabilizing catheter positions with a softer balloon and a more deflectable sheath. These novel characteristics may help achieve successful pulmonary vein isolation in difficult cases when conventional balloons are used. This study aimed to investigate the differences in the lesion profiles, touch-up radiofrequency rates, and anatomical predictors of acute PV isolation comparing the Poole and Arctic Front Advanced Pro cryoballoons. This is a retrospective study including 338 consecutive patients who underwent a first cryoballoon ablation for paroxysmal atrial fibrillation at the Keio University Hospital from April 2019 to September 2023. Using propensity score matching, the authors extracted 135 pairs treated with a Poole or Arctic Front Advanced Pro catheter, compared the procedural outcomes, and explored the anatomical predictors related to successful pulmonary vein isolations. There was a matched cohort of 270 patients with a median age of 67 years, 77% male. 1,535 cryoballoon applications were delivered for 1,063 pulmonary veins, and touch-up RFA was performed for 84 pulmonary veins in 67 patients. The rate of touch-up RFA was significantly lower for the right inferior pulmonary vein in the Poole group, 9.8% versus 21.6%, whereas there was no significant difference for the other pulmonary veins. A lower right inferior pulmonary vein frontal angle was linearly associated with a more favorable outcome for the Poole group than for the AFA Pro group, with an interaction p-value that was significant. The authors conclude that the touch-up RFA rate for the right inferior pulmonary vein was significantly lower in the Poole cryoballoon group than in the AFA Pro group, with a particularly pronounced difference for inferiorly oriented right inferior pulmonary veins. The title of the next paper is Rising Burden of Cancer and Atrial Fibrillation-Related Mortality Among Adults in the United States, 1999 to 2019 by Dr. Muhammad Saad and colleagues. Atrial fibrillation is the most common cardiac arrhythmia, whereas cancer remains the second leading cause of death in the United States, the authors state. They also note that both conditions share several risk factors and may compound mortality risk. However, national trends in AF and cancer-related mortality remain unexplored. The purpose of this study was to assess trends in mortality related to atrial fibrillation and cancer amongst U.S. adults between 1999 and 2019, using demographic and geographic stratifications. The data were obtained from the CDC Wonder Multiple Cause of Death data set. 148 patients 25 years and older with AF and cancer as an underlying or contributing cause of death were identified. Age-adjusted mortality rates per 100,000 population and average annual percentage change were calculated. The age-adjusted mortality rates for cancer and AF-related deaths increased from 4.95 in 1999 to 10.01 in 2019, with an average annual percentage change of 3.49. Males had a higher age-adjusted mortality rate than females, 10.24 versus 5.13. Non-Hispanic whites had the highest age-adjusted mortality rates, 7.89, followed by non-Hispanic blacks, 4.53, and Hispanics at 3.11. The Western region had the highest age-adjusted mortality rates, and non-metropolitan areas exhibited greater mortality rates than metropolitan areas. Individuals with lung cancer exhibited the highest age-adjusted mortality rates, 1.65, followed by gastrointestinal cancer, 1.52, and hematologic cancer at 1.00. The lowest age-adjusted mortality rates were observed in prostate cancer and breast cancer. The authors conclude that mortality from cancer and AFib has increased over time, with significant disparities across sex, race, and geography. Targeted interventions are required to mitigate these disparities. The next paper is called High Power Short Duration versus Conventional Radiofrequency Ablation for Atrial Fibrillation in Patients Over 80 Years of Age, a propensity score matched cohort analysis by Dr. Alex Tunch-Martinez and colleagues. As way of background, the authors offer the data on AF ablation using high power short duration ablation in patients over the age of 80 are lacking. The purpose of this study was to compare the safety and efficacy of paroxysmal and persistent AF ablation using high-power short duration versus conventional ablation in a propensity score-matched cohort of patients older than 80 years. There were 232 consecutive patients aged over 80 years and undergoing AF ablation. Propensity score matching revealed 102 pairs for maximizing comparability. A post-ablation 42-day blanking period was applied. Major complications were defined as those requiring intervention or causing sequels within 30 days following catheter ablation. The authors identified that the procedural duration, 132 versus 155 minutes, and X-ray exposure, dose area product 248 versus 544, were significantly reduced in the high-power short duration group. Safety endpoints, however, showed no significant difference, 4 out of 102 patients versus 7 under 102 patients. Freedom from any arrhythmia was not different between the groups, including a follow-up of 22.5 months with a hazard ratio of 0.71. After 1.52 procedures, 80.4% of all patients remained in sinus rhythm, with a lower number of repeat procedures in the high-power short-duration group. The authors conclude that in very old patients greater than 80 years of age, AF ablation using high-power short-duration approach can be performed safely and effectively, with a reduction of procedure duration, X-ray exposure, and fewer repeat ablations compared to a conventional approach. The authors state that long-term ablation results are promising with both approaches. The title of the next paper is Dual Atria Rotor Modification, a comparative analysis of rotor modification and posterior wall isolation in patients with persistent and long-standing persistent atrial fibrillation by Dr. Okana and colleagues. As way of background, the authors state that various methods have been devised for catheter ablation and persistent atrial fibrillation. However, it remains difficult to understand the mechanism of AF and to determine the optimal method. The purpose of the study was to evaluate the effectiveness of rotor modification compared to posterior wall isolation in the treatment of persistent atrial fibrillation. The study included 50 patients in the rotor modification group with a mean age of 67 years, and 76 of those with long-standing persistent AF, and 50 patients in the posterior wall isolation group with mean age of 67 years, and 66% with long-standing persistent atrial fibrillation. In the rotor modification group, in addition to cryoballoon isolation of the pulmonary veins, rotors in both atria were identified using a phase mapping system and ablated at low power. In the posterior wall isolation group, the pulmonary vein antrum and posterior wall were isolated together using a radiofrequency catheter. The primary endpoint was the maintenance of sinus rhythm, defined as freedom from atrial tachycardia, AF, and atrial flutter over a 36-month postoperative follow-up period. The authors found that survival curve analysis using the log-rank test revealed a statistically significant difference, p less than 0.001, demonstrating the superiority of rotor modification. The authors conclude that rotor modification is suggested to be as effective as posterior wall isolation or more effective in maintaining sinus rhythm in patients with persistent atrial fibrillation. The title of the next paper is Trends in Cardiac Conduction Disorder-Associated Mortality Amongst Young Adults in the United States, 2010 to 2020, by Dr. Marco Zuin and colleagues. As background, the authors note that cardiac conduction disorders in young adults aged 25 to 44 years represents an important and poorly investigated condition associated with death. The authors purposed to look at trends in what they call CCD as an acronym for cardiac conduction disorders, associated mortality in the United States from 2010 to 2020 amongst young adults to determine differences by sex, ethno-racial groups, urbanization, census region, and underlying causes of death. They obtained mortality data from the CDC, Control and Prevention, wide-ranging online data for epidemiologic research database covering the period from 2010 to 2020. Age-adjusted mortality rates were analyzed using joint point regression modeling and presented as the estimated average annual percentage change, AAPC, along with corresponding 95% confidence intervals. In the United States between 2010 and 2020, 4,312 U.S. young adults aged 25 to 40 died from CCD, equating to a rate of 10.9 deaths per 1,000 population. The relative AAMR increased with a seemingly exponential distribution without sex differences. Furthermore, the AAMR increase was more pronounced in white patients. The AAMR has similarly increased in both urban and rural areas. Higher absolute numbers of CCDs were clustered in the South, 45.1%. The most common underlying causes of mortality in U.S. young adults dying from CCD were cardiomyopathies, 11.4%, sepsis, 6%, myocardial infarction, 5.9%, pulmonary embolism, 4.7%, and poisoning by drugs, medications, and biologic substances at 4.5%. The key findings are that 1. Cardiac conduction disorder associated mortality amongst young adults in the U.S. increased from 2010 to 2020 with no significant sex differences. 2. The highest mortality rates were observed in the southern region, particularly amongst white, Black, and Hispanic Latinx individuals. And finally, cardiomyopathies were the most frequent underlying cause of CCD-associated deaths. The next paper's title is Trends and Differences in the Rates of Autopsy in the United States, 2003 to 2020, a nationwide analysis by Dr. Jeanne Nelson and colleagues. As way of background, autopsy is the gold standard for determining the cause of death, and it's declining globally. Significant differences exist between clinical diagnoses and those revealed at autopsy. Evidence of disparities in autopsy rates between different patient groups has previously been reported. The purpose of this study was to describe contemporary trends and disparities in autopsy rates according to sex, race, and urbanization, with particular attention to patients who have died because of cardiovascular disease. The authors accessed the Center for Disease Control wide-ranging online data for epidemiologic research for underlying cause of death data set for 2003 to 2020 to assess trends in autopsy rates in all comers and for different subgroups stratified by sex, race, and degree of urbanization. Further primary and subgroup analysis was performed independently by the International Classification of Diseases 10th Revision Cause of Death criteria by chapter, subchapter, and specific diseases of interest. Linear regression was used to assess trends over time, with a significant coefficient considered evidence of temporal trends. The authors note that the annual autopsy rates decreased across the time period in all comers, with an average autopsy rate of 3.66%. However, this relationship was not demonstrated in CVDs. Men undergo autopsy more frequently than women, though autopsy rates in women with CVD, that is cardiovascular disease, are increasing. Patients of non-white ethnicity and in metropolitan areas undergo autopsy at higher rates. Increasing autopsy rates are seen in ischemic heart disease. The key findings are that 1. Autopsy rates are declining in the United States, however, trends differ depending upon the patient's social and disease factors. 2. Male, non-white, and metropolitan patients are the most likely to undergo autopsy. Despite overall decreasing rate of autopsy in both males and females, female autopsy in cardiovascular disease is an increasing cause of death is declining globally. Next paper's title is Diagnostic Performance of the Fragmented QRS Complex on Electrocardiogram for Detecting Myocardial Scars Assessed by 3.0 Tesla Cardiac Magnetic Resonance Imaging by Dr. Kasin Nukulam. As way of background, the authors note that fragmented QRS complexes on a 12-lead electrocardiogram has been associated with myocardial scar. However, its diagnostic accuracy for detecting myocardial scars assessed by cardiac magnetic resonance imaging remains uncertain. The purpose of this study was to evaluate the diagnostic performance of QRS fragmentation for detecting myocardial scars assessed by the 3.0 CMR. Patients who underwent 3.0 Tesla CMR between May 2020 and May 2023 were included. A 12-lead ECG was assessed for fragmented QRS, defined as the presence of an R wave or notching in the nadir of the S wave in at least 2 contiguous leads. The diagnostic performance of fragmented QRS in detecting myocardial scars and corresponding left ventricular segments were analyzed. Overall, 1,692 patients were included. Fragmented QRS presented in 49% of the participants, which was more prevalent in men, those with a history of coronary artery disease, and those with myocardial scars. The sensitivity and specificity of the fragmented QRS from the ECG were 25.6% and 88.7% for anterior 21.1%, and 91.5% for lateral, and 42.9% and 63.4% for inferior segments. The key findings from this study are that 1. Fragmented QRS complexes had low sensitivity, 22 to 43%, and positive predictive value, 36 to 45%, making it an unreliable marker for myocardial scars on the 3.0 Tesla CMR. Second, fragmented QRS showed higher sensitivity and PPV for non-ischemic scars, although still insufficient for clinical use. Third, unlike single photon emission computed tomography with 99 MC STIMIBI, which overestimates scars, CMR provides higher accuracy, explaining the lower fragmented QRS sensitivity in this study. And finally, a 0.15 to 100 Hz filter increased sensitivity but reduced specificity, suggesting the routine 0.15 to 40 Hz filter may be more clinically useful. The next paper's title is Characterizing the Recurrence of Atrial Arrhythmia Following Macro-Reentrant Atrial Tachycardia Ablation in Adult Patients with Repaired Tetralogy of Fallot by Dr. Brett Pinsker and colleagues. The background of this paper is that the recurrence of arrhythmia following catheter ablation of macro-reentrant atrial tachycardia in repaired tetralogy of Fallot is poorly understood. The purpose of the study was to better describe the incidence, mechanisms, and predictors of recurrent atrial arrhythmia following macro-reentrant atrial tachycardia ablation in repaired TOF. Patients with repaired TOF at 18 years of age who underwent RF ablation for MRAT, and that is the acronym for macro-reentrant atrial tachycardia, and that included typical cavo tricuspid isthmus-dependent atrial flutter, incisional scar-mediated MRAT, upper and lower loop reentry, or left atrial MRAT, at Duke University Hospital from 1996 to 2023 were identified. Primary outcome examined was the first recurrence of atrial arrhythmia lasting 30 seconds or more, captured on a 12-lead ECG, ambulatory monitor, or EP study. Predictors of outcome were identified using Cox regression and Kaplan-Meier survival analyses. Amongst 58 patients who met the inclusion criteria, 39, or 67.2%, developed the primary outcome over an average follow-up of about 5 years. 9 patients, which was 15.5%, underwent repeat second or third ablation for recurrence of an index MRAT that was targeted during the initial ablation. Right atrial area with a hazard ratio of 1.60 in the presence of AFib or focal atrial tachycardia at ablation were predictive of the primary outcome. Right atrial area, 26 centimeters squared, was associated with decreased arrhythmia-free survival. The author's key findings are that 1. Following ablation of macro-reentrant atrial tachycardia and repaired tetralogy of Fallot, recurrence of atrial arrhythmia is common and often of distinct mechanism. 2. Right atrial size and the presence of atrial fibrillation or focal atrial tachycardia at the time of ablation may help predict the recurrence of atrial arrhythmia. And 3, extended courses of post-ablation anticoagulation may be beneficial in this population. The next paper's title is A Drop in the Atrial Ventricular Conduction Curve and Dual Pathway Electrophysiology by Dr. Jeanne and colleagues. As way of background, the authors offer that atrial ventricular conduction time is rate dependent. As the atrial coupling interval, or the A1-A2, shortens, AV conduction time A2-H2 prolongs. Thus, the AV conduction curve plotted using A1-A2 versus A2-H2 is usually smooth and monotonic. A jump in the curve is the current clinical criteria for dual pathway electrophysiology, whereas a gap in the curve has also been described. The purpose of this study is to describe a new phenomenon called a drop in the AV conduction curve. The potential relationship between a drop in the AV conduction curve and the dual pathway electrophysiology was also examined. The authors looked at 81 experimental records from rabbit AV nodal preparations containing the following data: at least 1 AV conduction curve, and 2 had a recording of His electrogram alternans, which is, they state, a validated new index of dual pathway conduction. Most cases had intracellular action potential recordings from the AV nodal fibers. Of the 81 preparations, 3 of them showed a drop in the AV conduction curve. The drops at A1, A2 always occurred after fast pathway to slow pathway transition. The drop showed a slow pathway, fast pathway pattern in 2 of the 3 preparations and a slow pathway pattern in the remaining 1 preparation. Drops were associated with and most likely caused by the formation of intranodal nodal atrial reentry and its subsequent conduction. The authors concluded that a new phenomenon, a drop in the AV conduction curve, has been demonstrated in this study, and that a drop is likely caused by the formation of intranodal nodal atrial reentry and its subsequent conduction. Next up is a paper titled ECG GraphNet, Advanced Arrhythmia Classification Based Upon Graph Convolutional Networks by Dr. Myung-Gun Lee. The background is that deep learning has significantly improved medical diagnostics, particularly in electrocardiogram analysis, yet accurate classification of arrhythmias remains challenging. These authors propose an electrocardiogram graph convolutional network, or ECG GraphNet, a graph convolutional network designed to classify arrhythmias into three types: normal, supraventricular ectopic, and ventricular ectopic. By way of methods, the ECG GraphNet utilizes a novel graph representation of ECG data, in which the P-wave, QRS complex, and T-wave are modeled as individual nodes. A unique QRS center weighted average pooling method is employed to enhance beat-specific feature extraction. The authors systematically explored various aspects, including node features, edge definitions, a data augmentation method, and architecture configuration to determine the optimal model design. Experiments were conducted on 10-second ECG recordings from 328 patients using a single lead device. In terms of their results, the optimized ECG GraphNet achieved a macro F1 score of 88.6% in five-fold cross-validation. Scalability experiments further demonstrated its robustness with macro F1 scores of 85% and 87% across diverse ECG patterns and sizes. The author's key findings are that 1, they have developed ECG GraphNet, which transforms P, QRS, and T segments into graphed nodes with dynamic edge relationships. This novel graph structure precisely captures both temporal and morphological features of cardiac signals, overcoming the limitations of traditional neural networks in processing variable length ECG data. Second, the authors introduce a QRS-centered pooling method specifically designed for ECG graphs that effectively preserves critical beat-specific information. This innovation significantly improves the detection of subtle beat-to-beat variations crucial for arrhythmia classification. And third, through extensive experimentation, the authors state that they have developed an optimal graph representation method incorporating embedded signal features and distance relationships, achieving a remarkable macro F1 score of 88.61% in classifying normal, supraventricular ectopic, and ventricular ectopic beats. The authors validate their approach using a real-world data set from 328 patients with a commercial patch-type single-lead ECG device, demonstrating its scalability and robustness in clinical settings. Next up is a paper titled Newly Diagnosed Atrial Fibrillation Detected by Non-Invasive Screening Methods in Clinical Practice by Dr. Luis Aguinaga and colleagues. As background, the authors note the patient characteristics and outcomes of newly diagnosed atrial fibrillation have been investigated in large registries. The purpose of their study is to address the role of non-invasive screening tools in diagnosing atrial fibrillation in the Argentinian clinical practice. This was an observational retrospective study. Patients' clinical characteristics and management of newly diagnosed AF detected by a non-invasive screening tool were analyzed. The authors note that of 12,635 AF outpatients, 17.1% of them had newly diagnosed AF and were detected by a screening method using ECG monitoring service, 82.3%, self-pulse palpation, 17.3%, and smartwatch or smartphone at 0.4%. Screening patients were older, 73 versus 72 years, which was a non-significant difference, and had a higher prevalence of 75-year-olds, 45.5% versus 37.9%, which was significant, and women, 42.5% versus 41.2%, which was not significant. Adjusted results by multivariate analysis showed that alcohol consumption, thyroid dysfunction, coronary artery disease, paroxysmal atrial fibrillation, being asymptomatic, having a high risk of thromboembolic and bleeding complications by the CHA2DS2-VASc score and the Hasblad score, as well as heart failure, were associated with the screening patients. Although no difference in the oral anticoagulation therapy was detected, vitamin K antagonists were less frequently prescribed. Electrocardioversion was preferred over class 1 and class 3 antiarrhythmic drugs. The next paper is a research letter and part of our Global Voices section. The title is Setting Up an Electrophysiology Laboratory in Rwanda, A Journey of Collaboration and Innovation by Dr. Willie Musayo and colleagues. As the author states, until 2024, Rwanda lacked electrophysiology services capable of diagnostic EP studies and catheter ablation. Before then, only permanent pacemakers were routinely implanted. Radiofrequency ablation has demonstrated an improvement in quality of life and a reduction in costs in a variety of contexts. There is a need to establish cost-effective and sustainable EP services in low and middle-income countries such as Africa, where access to them remains severely limited. Establishing an EP service in Rwanda posed significant challenges owing to the high cost of EP laboratory equipment and the scarcity of skilled labor. In addition, the absence of technical representatives for EP equipment in the country was an additional obstacle. However, for the first time, the authors successfully performed EP studies and ablation in their country. This article outlines their experience in establishing the EP service, highlighting the technology, key contributors, and tasks involved, with a focus on the essential role of stakeholder engagement in achieving this milestone. The author's key findings are that 1, electrophysiology study and ablation procedures were performed for the first time in Rwanda. 2, resourcefulness and innovation were crucial in acquiring and setting up the necessary equipment. And 3, stakeholder engagement was key in achieving this milestone. Next is a brief report with title Isolation of a Persistent Left Superior Vena Cava using the Circular Array Pulsed Field Ablation Catheter by Dr. Yosuke Mizuno. As way of introduction, the authors state a persistent left superior vena cava is the most common thoracic venous anomaly in adults and provides a substrate for arrhythmogenesis. While thermal ablation to create a PLSVC isolation has been reported, it remains technically challenging and carries a significant risk of collateral damage to adjacent structures. A standardized approach has yet to be established. PFA is a novel, non-thermal modality that induces irreversible electroporation of myocardial cells. This technique minimizes injury to adjacent structures during catheter ablation, such as the esophagus and phrenic nerve, by preventing apoptosis in surrounding tissues. Although preventing studies have shown the feasibility of PLSVC isolation using pentaspline-type PFA catheters, no other catheter designs have been reported. The authors state that herein they evaluate the efficacy of the novel circular array PFA catheter, the Pulse Select catheter by Medtronic, as a safe and effective alternative. Their key findings are number 1. To their knowledge, this is the first comprehensive report on persistent left superior vena cava isolation using the novel circular array type pulsed field ablation catheter, Pulse Select, highlighting its efficacy and safety. Second, the over-the-wire small diameter design of Pulse Select makes it suitable for persistent left superior vena cava isolation and enables precise application to the contact surface within the left atrium. And third, persistent left superior vein isolation by Pulse Select was successfully completed in all cases without complications. In contrast to conventional thermal ablation, PFA reduces the risk of damage to surrounding tissues. The next paper is a point of view. The title is Solving the Problem of Durable Pulmonary Vein Isolation by Targeted Pulmonary Vein Sleeve Ablation with Pulsed Fields by Dr. Jacob Koruth and colleagues. Here are the statements according to the authors. First, pulsed field ablation for pulmonary vein isolation has not been associated with phrenic palsy or pulmonary vein stenosis. Second, durable PV isolation continues to be difficult to achieve despite the advent of PFA. And 3, that we should consider targeted ablation of the electrically active PV sleeve and carina to improve PV isolation durability, but with a dedicated safety assessment. The authors also state that they believe it is time to consider purposely targeting the entire myocardial sleeves for all PVs, including the carina. The amount of ablation should be individualized to only the electrically active portion of each patient's PVs as identified by electroanatomic mapping so that procedural efficiency is maintained. Also, that this approach initially can be added to the legacy antral isolation such that both PV ablation and PV isolation are achieved. And finally, several current multi-electrode PFA catheters are already used by operators beyond the PV ostia as part of their PVI ablation workflow, and the authors state they recommend that this be purposefully performed. Finally, they also state it is reasonable to explore the efficacy of restricting ablation to PV ablation in patients with paroxysmal AFib, as the studies that established superiority of antiablation were largely performed in an era where PV reconnections were frequent. They conclude with stating a dedicated safety evaluation for PV stenosis, phrenic injury, procedural and catheter dwell times, and patient tolerance will be needed if routine PV and carina ablation is to be considered. The next paper is a brief report. The title is Catheter Ablation for Atrial Fibrillation in Patients with Tricuspid Regurgitation by Dr. Eisenegger and colleagues. The background is that contemporary guidelines recommend early rhythm control strategies, including catheter ablation for patients with symptomatic atrial fibrillation. However, the impact of coexisting tricuspid regurgitation on procedural characteristics and the efficacy of catheter ablation for atrial fibrillation remains unclear. The purpose of the study was to assess procedural characteristics and the efficacy of catheter ablation in patients with AFib and moderate to severe TR. The author's key findings are first that this is a retrospective analysis of patients with moderate or severe TR undergoing catheter ablation for AF in the Swiss Atrial Fibrillation Pulmonary Vein Isolation Registry. Second, all patients underwent transesophageal echocardiography 1 day before catheter ablation. Third, patient characteristics, procedural details, and long-term follow-up data, including serial electrocardiograms, outpatient clinic visits, and Holter ECG were collected for all patients. Next, in patients with atrial fibrillation and moderate or severe tricuspid regurgitation, catheter ablation was associated with a 1-year arrhythmia-free survival rate of 60%. Next, improvement in TR severity by at least 1 grade was observed in 63% of patients following catheter ablation, with significantly greater improvement amongst those without arrhythmia recurrence. And finally, all ablation modalities, including pulsed field ablation, were feasible in this population, with no significant differences in outcomes between energy sources. The authors conclude that these findings suggest that successful rhythm control via catheter ablation may contribute to reverse remodeling and improvement in tricuspid regurgitation, highlighting the importance of early rhythm intervention in this patient group. The next paper, which is also the last paper, is called Efficiency of an Artificial Intelligence-Aided Portable 12-Lead Electrocardiogram Acquisition System by Dr. Meghna Gautam and colleagues. The background for this is that although a 12-lead electrocardiogram has been the cornerstone diagnostic tool for arrhythmia diagnosis for more than a century, proper acquisition can be time-consuming and intrusive and is not always universally available owing to device size and cost. The Cardia 12-lead by AliveCor is a U.S. FDA-approved portable AI-aided ECG system that generates a full 12-lead ECG with only 5 electrodes. The purpose of this study is to evaluate the efficiency of the Cardia 12-lead system compared with standard 12-lead electrocardiograms in the outpatient clinical setting, with a secondary objective to evaluate the performance of the Cardia 12-lead ECGs defined as treating electrophysiologists being satisfied with the quality of the Cardia 12-lead tracing and not requesting an additional standard 12-lead ECG. The key findings in this study was that the Cardia 12-lead significantly reduced ECG acquisition time compared with standard 12-lead ECGs, 7.1 minutes versus 10 minutes, and that the Cardia 12-lead signal quality was sufficient for clinical use in greater than 90% of patients. Well, this ends the August 2025 HRO2 podcast. Thank you as always for listening. I look forward to bringing to you in September another group of wonderful papers.